You're listening to Medscape's In Discussion series on multiple myeloma, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Joseph Mikhael. Dr. Mikhael is a professor in the Clinical Genomics and Therapeutics Division at the Translational Genomics Research Institute, an affiliate of City of Hope Cancer Center. He is also the Chief Medical Officer of the International Myeloma Foundation. Dr. Mikhael is a consultant hematologist and Director of Myeloma Research at the Honor Health Research Institute, where he conducts Phase 1 clinical trials. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, my name is Dr. Joseph Mikhael, and welcome to Season 2 of the Medscape In Discussion Multiple Myeloma podcast series. Today, I'm very excited about the topic, which is when is the best time to use CAR T-cell therapy in multiple myeloma? Answering this incredible question today is an incredible friend and clinician, Dr. Krina Patel. Dr. Patel is an associate professor in the Department of Lymphoma and Myeloma in the Division of Cancer Medicine at the MD Anderson Cancer Center. She is the section chief for multiple myeloma and indeed the research lead in multiple myeloma. She has participated in many trials relating to CAR T. She takes care of a lot of patients with CAR T-cell therapy and indeed bispecific antibodies. And I just think it's wonderful to have this discussion with her because I think her perspective will be outstanding. So Dr. Patel, welcome to the Medscape In Discussion Multiple Myeloma podcast.
Fantastic. Thank you so much. This is such an exciting topic. And every time we talk, I'm always like, oh, this is the best time to talk about this because there's new things happening. And again, this is the best time to talk about this because there's so much happening for our myeloma patients. That's all really, really amazing.
Absolutely. I couldn't agree more. And as just sort of quick backdrop and background to our audience today, of course, we're all familiar with CAR T or chimeric antigen receptor T-cell therapy. This really remarkable therapy where we can collect T cells from a patient and then manufacture them in such a way that they express a receptor that is specific to their myeloma cell. Currently, the CAR T cell therapies that we used are directed against BCMA or B cell maturation antigen on the myeloma cell. We have two current CAR T products available to us, ide-cel and cilta-cel, that were first approved in patients who had at least 4 prior lines of therapy. But now we have access to them much earlier. We can give cilta-cel as early as first relapse and ide-cel as early as second relapse. And so that has put us in this situation where we have to make this decision of when do I use CAR T-cell therapy, hence the podcast today. My last introductory comment as we start to get into the discussion here, Krina, is that we have seen really remarkable response with CAR T-cell therapy. The fact that in very late line multiple myeloma, where patients have had on average 6 prior lines of therapy, with cilta-cel, we still saw a response rate over 90%. We've still seen progression-free survival in years, not in months. And more recently, we saw in the CARTITUDE-1 long-term follow-up, a third of patients 5 years after their single-cell infusion are now completely disease-free, which is truly remarkable. And so the hope is, well, maybe if we use it earlier, it's even better. And we have preliminary results of studies. And I'd be happy to have you talk to us, even just at a very high level, about those earlier studies. Historically in myeloma, if I use something in very late line, I get a certain response. If I use it in earlier line, I get an even better response. Is that true of CAR T-cell therapy? Because I know there have been some docs who have said, oh, you only get X amount of benefit of CAR T whenever you use it. So let's start with that premise, because that, I think, is going to be important to answer the question.
I think that's a huge question. And my short answer is yes, it's better when you go earlier. And we do see a better PFS. More patients are both in CARTITUDE-4 and KarMMa-3, which is KarMMa-3 is the ide-cel early line and basically 3 lines or more. Both of those show better PFS so far and based on the follow-up they have. Of course, the follow-up is a lot shorter than their late line studies, but ide-cel, again, it was 8.8 months in their late line versus 13.4 months in their early line. Patients are different in these different trials. There are a lot of high-risk patients in KarMMa-3. But if you look at the cilta-cel data, they did something where most of us wouldn't do. But to answer this question, they put their PFS, curves and overall survival curves for CARTITUDE-4 and 1 together to show that there are many more patients at year 1 and year 2 in CARTITUDE-4 that are still progression-free compared to those that were in CARTITUDE-1, right? So the hope is that at 5 years, when we have that data, I'm hoping we have 40, 50%, maybe even more instead of that 33% that are 5 years out. Again, we don't have the long-term data, but predicted, it looks like we're going to have a plateau at a higher level percent of patients that are still PFS down the road.
And I guess that doesn't really surprise us, right? Because I mean, we've seen this before. Typically, when we've used almost any strategy in later line, that it works better in earlier line. I know that historically, one of the very important modalities in myeloma, you've probably heard me say this, Krina, and I say it a little bit jokingly that, saving the best for last is great for a Hallmark romantic movie, but it's not what you want to do for myeloma. So, with that premise, I mean, maybe the question today is just super easy to answer. Like, why wouldn't we just give every single person who potentially, I guess, would be eligible CAR T cell therapy at first relapse? I mean, is this just a simple question? We say, oh, we get better PFS, we get better, ideally, it looks like overall survival. Why wouldn't we just move everybody to CAR T upfront?
No, I completely agree. And I think that's actually the fair thing to talk to patients about early on, right? Every patient has their own reasons why they want to do something versus another. And in myeloma, the embarrassment of riches that we have, right? There might be special situations where a patient can't do it, but I think every patient deserves to at least hear about CAR T. And I think majority, if they hear about it and they have access to it, are going to do it. And this is on a daily in my clinic when we talk about these things, it's the PFS, but it's that time off therapy that is so big as well to really make sure that, we discuss that quality of life piece that if you get years without any treatment and your myeloma is under control, you feel fantastic. You actually feel normal, as my patients say. And I think, being able to do that earlier where you get more years in your younger years, just feeling great, I think is really important.
I agree with you. I joke with my patients and say, look, after we give you CAR T cell therapy, I then give you my favorite drug known as nada, known as nothing, right? And
Right.
patients love every insurance company covers it, everybody, and I don't mean to make light of it. I just mean that it really is a one and done approach. Now, to drill down on this a little bit more, though, I was at a meeting recently with some of my colleagues from my former institution at Mayo Clinic. And Mayo came out and said, well, in general, they're not offering it at first relapse unless someone has particularly high risk disease. They're worried a little bit about some of the toxicities. And I know we're going to talk about toxicity a little bit later, but their sort of favorite approach has been let's give patients another line of therapy. So their second line of therapy with, a more conventional triplet or what mechanisms of action they've not yet seen, and then consider CAR T at, if you will, third line, where at least ide-cel we know is also made available. What's your response to that, Krina? Do you feel that that's I mean, of course, everything may be a reasonable strategy, and you said it yourself, the patient really has to be centered to make that decision. But why would you favor going earlier than always waiting until someone has had 2 prior lines to give them a CAR T?
Yeah, I think it comes back to, when we first started a year ago, when we got this out, that I was really looking at patients who had high risk, functional high risk or other high risk features. I mean, those are the patients that never get to CAR T in fifth line, right? There's that group of patients that when we first got CAR T, we knew they were never going to get to cell infusion. And the studies show that even in early line, there are some patients who just their myeloma takes off and they can't get to cell infusion. It's a little different in the real world where I don't have to worry about active disease or their disease can't be treated too well, that we can actually use it as a consolidation. So for that, I would say my high risk patients, yes, I want to get them in second line. But as we've evolved, as we've learned about the toxicities that we will talk more detail about later, it's becoming safer. I'm understanding it better. I can predict a little bit better in terms of how do we improve that toxicity profile that now I tell my patients, hey, we have this 5 year survival data for 33% of the patients in late line. So my standard risk patients hear about it. And I will tell you, 3 out of 4, at least right now, will say, I want CAR T. And again, talking about that potential of years off therapy, being able to have this fantastic response at quality of life. I have had patients go back to work when they were on disability before because they just had to keep coming in for treatment. It really improves their outcomes. And so again, for us, we're actually offering it to everybody. And if people want and standard risk want it, we do it. Because again, we learn the toxicity a little bit more now. And it's not necessarily, a high risk of really bad toxicity that our patients are going to, end up with. So I think it's important to discuss it.
Yeah, no, I think this is great, and I was gonna sort of plan to talk about toxicity a bit later, but let's just get right into it now because it's so central. Because I've heard similarly some of the concern about CAR T earlier on is some of the more severe long-term toxicity. So someone will say, look, when someone's standard risk at first relapse, yes, if I give them a triplet, I may not get much more than a couple of years, maybe 3 years, depending if they've not seen a CD38 antibody yet, but I don't have this risk of very worrisome neurological toxicities, whether it's Parkinson's or Guillain-Barré or something like that. But as the patient has more lines of therapy, they're obviously more accepting of potential risk. And you made an interesting comment that things have changed even from a year ago, and I'm old enough to remember the early days where, we had so few choices that you didn't really have choice in myeloma, but that every single treatment we give in myeloma has evolved over time. I find it fascinating that pretty much every drug we give, we don't give it the way it was first given, meaning we don't give IV twice weekly bortezomib anymore. We don't give twice weekly carfilzomib as much as we used to, or twice weekly selinexor. We've gone way down on our dosing of IMiDs. I wonder here if you can talk to us a little bit about the evolution of the toxicity of CAR T cell therapy, how we have been able to reduce that toxicity, what strategies we take to do that, because our clinicians listening today might be sort of afraid to refer that patient at early relapse because of some of those potential toxicities. But I think we can reassure them that we're further ahead of where we were. We still have some ground to cover. But what's your take on that, KP?
It's really important to know that it's not the same as when we first started. And early line patients are very different than late line patients. I will say, anecdotally, you're going to have more data from the real world and the consortiums in the future for early line outcomes. But just the patients I've been able to treat in the last year in early line, it is so much easier to just get them home because I don't have to have these conversations of, okay, you still need transfusions. You still have CMV that's going up. I'm worried you might need a stem cell boost because your counts are so low right now. And so the number one difference I will say is the counts that, in late line, cytopenias are such a big deal that usually their local doctors have to still take care of those patients and still give transfusions, et cetera. Versus in early line, some of my higher risk patients that have a little bit more aggressive myeloma might need it into their second month. But all of my standard risk patients and the majority of most of my patients, day 30, they're great. And they're really not needing much at all. They might get blood tests, but they're not needing anything. They're not needing GCSF or transfusions, which is huge. It's just tells you that their bone marrow is just so much stronger. And then that decreases the risk of serious infections. Of course, we still give supportive care, IVIG, PJP prophylaxis, that type of stuff, but they're not getting the infections. And so even when they get infections, they get through it much better. In late line, if someone got COVID in those first 3 months, I freaked out. I was like, okay, get to the hospital. Let's find remdesivir. Let's find something to make sure you don't, nothing bad happens. Now my patients, because of the fact, again, their bone marrows are just stronger. They're doing better with minor infections, colds, things like that. They actually do really well with it. And I don't have to tell them they have to come to the hospital. So those are already improved.
So just moving to earlier line therapy has already sort of reduced the burden of the toxicity. And let me just add to what you've said. This isn't just the Dr. Patel experience at the world famous MD Anderson. You remember the very first report of Karma 3 and of Cartitude 4, those two studies that were done in earlier line, when they compared them to their later line, in both situations, we saw less toxicity, even in the clinical trials. So step one is, if I'm hearing you, even just moving to earlier line therapy is helping to reduce the burden of toxicity, in particular infections and cytopenias thereafter. But what in addition, what have we learned in terms of our strategy in approaching patients to, their burden of disease beforehand and what we do afterwards with IVIG and the like? What are the things are we doing that is further reducing the toxicity risk that might, again, put a patient and their provider into a situation where they feel more comfortable going ahead with CAR T and earlier line therapy?
No, and I think this is where this delayed neurotoxicity, right? That's the other big side effect that in Cartitude 1, for instance, 6% of patients had this weird delayed neurotox that people were just like, what does that mean? Guillain-Barré, Parkinsonianism. And from Cartitude 4, we actually learned that giving better bridging, where patients have less tumor burden going into the actual CAR T infusion, that risk goes down to 0.5%. And so, what basically both Karma 3 and Cartitude 4 have shown, CRS, ICANS, again, this delayed neurotox, some specific things to myeloma CAR Ts are much, much lower when you have better disease control. And when people respond to bridging, so Karma 3 showed this, that they respond to bridging, they have less tumor burden, they have more effector cells, the T cells, per tumor cell, we call the ET ratio, the less toxicity they have and the better efficacy they have. And I think the main thing about that is in early line, when we give bridging, we have options to give bridging that work, right? In late line, all of a sudden, there's very few options. And so it's a lot harder to get that E to T ratio the way we want it. But in early line, the majority of my patients are responding to their bridging therapy, or I can give another cycle of it if I need to. If it's not working well enough or I need to change it, I actually have time to do that in that early line patient versus in late line, we're just rushing against time basically.
And to clarify, and just to make sure our audience is with us on this, we define bridging therapy as the treatment that's given after the T cells are collected and before they're reinfused. So literally that immediate bridge, the sometimes called holding therapy or prior line therapy is what we give even before. Do you have any advice for our clinical audience in what that prior line should or should not have in it? So whether it's at first relapse, second relapse, or 10th relapse, when that doctor is saying, okay, I think I need to send you to Dr. Patel to think about getting CAR T, do you have advice for them as to what they should or should not be treating someone with before we even collect their T cells?
Yeah, I think 2 points on that. One, it's not just the prior line, but it's even the lines before that. So if you are sending someone to us that has had years of alkylator therapy, way harder to actually make those T cells. We get out of spec products that we don't know if they're going to work as well. Manufacturing fails sometimes. So the alkylators are the biggest ones for us that we say don't have someone on Cytoxin for many, many years before they come to us for CAR Ts. Bispecifics, it's a little bit questionable how long they have to have been on those. But again, there are some patients that are on it till relapse, a year, year and a half, and it is harder to make those T cells right after. So we're learning a little bit more. Is there a washout period? Is there something we could do in between, like an IMID that can help those T cells first? We don't 100% know. But this is, again, why we try to do CAR Ts prior to bispecifics for that reason as one. But two, we just know they do better with PFS 1 and 2 if they get a CAR T first, and then a bispecific down the road if they need it. The main thing I wanted to say is if you can send a patient to us either before they're relapsing when they're eligible so that we can actually get everything ready for them to potentially go to CAR T next, or as they're biochemically progressing, let's say they haven't hit relapse yet, but they are about their M proteins going slowly up. It is much easier for us to get slots these days. So if you send me a patient, I can talk to them about CAR T, we can educate them, and then as soon as they're ready, we can actually put in for the insurance approval and get a slot the next week. And so it's much faster to have already seen that patient and get all the logistical things done, that sometimes we don't have to do that, salvage or the holding therapy, because we can just get the cells collected and they go on to their bridging therapy instead. And we really talk to the community doctors, and their local doctors about that, to say, hey, this is the date of apheresis. What do you want to do for bridging? Let's talk about it. Can you get it started the day after? Right. So that maybe it won't affect the T cells right before we collect.
Wow, that's fantastic. Oh, so much to take in there. That's great. So take home messages here include, don't wait until the disease is really exploding. Be cautious in the use of alkylator therapy before, and clearly have a conversation, have a good discussion with the CAR T center. Before we move on to the next section where I want to talk to you about the two different kinds of CAR Ts really quickly, can you also give advice to the community clinician after someone's had their CAR T? I mean, I know typically we're more involved in their care for the first several weeks, but very often these patients need to stay on IVIG for a long time, don't they?
For sure. I think it's a little different than bispecifics where we keep IVIG on the whole time they're on a bispecific. But I will say the majority of my patients probably need IVIG monthly, at least for the first 6 months. And then we tend to do PJP and VZV, shingles prophylaxis for about a year, 6 months to a year. Again, late line, longer, because I know their T cells are really beat up. Early line, we're kind of figuring out, can we stop at 6 months or not? Because again, they're early line. We'll learn more, but we do want to keep them on prophylaxis. But that's really all I need to do for the majority of these patients is that IVIG and those two prophylaxis, and then just monitor their counts every so often in early line. Again, it's me having a conversation on Zooms with local labs, and it's just, oh, where'd you go? My patient went to Japan. I'm like, fantastic. I'm living vicariously through you now. Those are the conversations I get to have with these patients, which is amazing. I think the other big thing, is the monitoring of the myeloma. The first 6 months, I do it once a month, but then we go to every 3 months. So these patients aren't really having to follow up even with blood work as often. It's been really impressive to see that we're talking about survivorship clinic, like building
Wow.
survivorship clinics in myeloma now because of these patients.
That's so wonderful. That's so wonderful. Well, I have two sort of final questions for you in the last 4 or 5 minutes we have here. First is, do you use both of the CAR T products we have available to us, ide-cel and cilta-cel? Is there one that you may favor one over the other as you're deciding when is the best time to give CAR T cell therapy?
Great question. I think cilta-cel being in second line, it's available for more patients earlier. So I do talk about it much more for the majority of my patients in second line. Cilta-cel is a fantastic CAR T. The efficacy is amazing. We have this long-term data for PFS, but there are still some toxicities that I worry about for my older patients or my frail patients. And, we have some subset analyses we've done where maybe ide-cel is actually better in that group of patients. My octogenarians, even if they're fit, they don't have as much reserve if something bad does happen. And I do have patients that have done really well for 3 to 5 years. And it happens to be our older patients that do really well with ide-cel in terms of their PFS as well. So I tend to do ide-cel there. The other big group is my patients with renal insufficiency. So the one difference here with CAR T, because of the lymphodepletion chemo, you do have to dose reduce if your kidney function isn't very good with fludarabine, and then that affects the CAR T expansion. And with cilta-cel, the CAR T expansion happens in the second week. So changing that lymphodepletion seems to have a little bit more effect on it versus with ide-cel. The lymphodepletion's all done at the beginning and the expansion happens all at the beginning. So it's a little easier to predict both efficacy and toxicity. So again, those are the two big groups of patients I probably do more ide-cel for. And then the rest, especially my high risk patients, I will try to do cilta-cel for.
Excellent. Wow, that's so thorough, so helpful. Well, Krina, believe it or not, we're getting towards the end here, but we have to address I guess the so-called elephant in the room, which is access, right? I mean, it's one thing when
I
someone
agree.
lives in Houston down the street from you and they can get it. And I know I've been working hard in a lot of areas of geographical access, but I think one of the things that also helps people make the decision when is the best time to get CAR T is, of course, can the patient even get CAR T? Can you just comment very quickly on what we've recently heard from the FDA that is making it actually a little bit more accessible?
It's really exciting. I think the fact that the FDA just got rid of the REMS requirement that patients have to be at a center for 4 weeks, can't drive for 8 weeks, has to have a caregiver that entire 4 weeks. They actually recently changed it to 2 weeks for everything. So you have to be near the CAR T center for 2 weeks, have to have a caregiver for 2 weeks, and don't drive for 2 weeks during that time. I want to say this is really important and exciting, and I think will improve access because, again, caregiver support for somebody else to take time off work is one of the biggest issues for a lot of people. So this will decrease that. Even for patients that are getting help, getting coverage for these things, that cost reduces. So hopefully we can help more patients that don't have the ability to afford all of this. But I will say for cilta-cel, for us, we're still saying 3 weeks just because the CRS ICANS doesn't happen until that second week. So we want to watch them a little bit longer, but that still cuts off some time. But this means that we need to work with our community oncologists even closer because they will be taking over those patients earlier. But that'll be great for our community doctors to be able to see these patients sooner and help with taking care of them, in that later part of their first few months. So really exciting.
I think I agree with you. I mean, I think this is just such fundamental. In fact, in the earliest days of CAR T, I had the privilege of writing an editorial about this whole concept of access. And we've
Right.
seen a huge change over the last several months, more manufacturing, more slots for apheresis, more access. And now with this reduced time commitment, I think we're going to see even more patients. Well, I think we have hopefully answered a good part of this question, Krina, and it's time to wrap up. Today, of course, we've talked with Dr. Krina Patel from MD Anderson about when is the best time to use CAR T cell therapy in multiple myeloma, and I hope this has been helpful to you. Thank you so much for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on multiple myeloma. This is Dr. Joseph Mikhael for the Medscape In Discussion Multiple Myeloma podcast.
Thanks for listening to Medscape's In Discussion Multiple Myeloma podcast series with our host, Dr. Joseph Mikhael. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on multiple myeloma.